Pneumonia is probably one of the easiest diseases to diagnose on your boards. You get a little coughing, a little fever, and a chest x-ray that confirms your diagnosis. And yet, this is one of the easiest points to miss on the PANCE because the PANCE doesn't care about rote memorization of facts, it wants pattern recognition and what you're going to do next. My name is Maruf, and in this video, we'll go over pneumonia exactly the way that the boards test it. Let's dive right into it. Now, when you get down to it, pneumonia is just a fancy word for an infection of the lungs. Now, this is going to be a problem because it's going to inhibit patients from taking in enough oxygen or exhaling enough CO2. Now, in reality, pneumonia can be caused by a myriad of bacteria, viruses, fungi, and this is where most students feel overwhelmed. But stick around, I promise in a few minutes we're going to simplify that expansive list so that we learn it in a very efficient and effective way. First, though, we need to talk about the ways that pneumonia can present. Most patients who develop a bacterial pneumonia will present with a very classic manifestation, that productive cough, a fever, pleuritic chest pain, or some sort of abnormal lung sound on auscultation. Now, that could be crackles from alveoli trying to open up against the inflammation around it, or it could be like decreased breath sounds if a good chunk of those alveoli are filled with inflammatory fluid, so there's no actual air that can get into that segment for you to hear. These typical presentations are most commonly caused by strep pneumoniae, the most common cause of bacterial pneumonia overall. So if you have a patient with this classic presentation, think strep pneumo first. However, the PANCE will sometimes add additional features to suggest a different bacteria as the cause of the patient's pneumonia. For example, if the patient has these pneumonia symptoms, but also has a history of COPD, then the boards wants you to think H. flu as the most likely pathogen, given that H. flu loves chronically inflamed lungs. Now, if the patient has a history of alcohol use or diabetes mellitus, then the boards wants you to think about Klebsiella pneumoniae as the most likely culprit. Now, back in the old days, they would describe these patients as having this bloody sputum described as currant jelly, but don't rely on this description. If you see a pneumonia in a patient with alcoholism, think Klebsiella. If the patient recently had influenza, was improving, but then all of a sudden has pneumonia symptoms, then the boards is trying to steer you towards Staph aureus as the most likely culprit. Influenza has this habit of destroying the ciliary escalator in our airways that normally helps to keep pathogens out of the lungs. This is now going to allow for opportunistic infections like Staph aureus to take over and sometimes even cause cavitations of the lungs if you get aggressive disease. If a patient comes in with pneumonia symptoms with a recent history of choking or aspiration, then think anaerobes. Now, sometimes the boards won't say directly that the patient aspirated, but instead give you context clues to suggest an aspiration, like a patient with acute altered mental status that couldn't protect their airway from aspiration, or a patient with chronic dysphagia from a prior stroke. Sometimes they'll provide a very telltale sign of anaerobic pneumonia, like a foul-smelling sputum. But again, don't rely on this to consider anaerobes because the boards are trying to move away from these buzzwords. Instead, if you have a patient who couldn't protect their airway, think anaerobes. So this is an extremely high-yield slide for the boards, so make sure you take the time to understand this outline well. These bacteria each have a multitude of other features, but they're not unique and therefore not really helpful for distinguishing these bacteria from each other. So for example, I can tell you about how aspiration pneumonia from anaerobes favor the right lower lobe, but this site is not exclusive to anaerobes, and other pathogens can also cause pneumonia in that right lower lobe. I can tell you about how strep pneumoniae causes a rusty-colored sputum, but in reality, all of these pathogens can cause a very similar looking sputum. So since these features are non-specific, I generally find them less helpful for the boards and just great trivia factoids on a Friday night. Now, some patients might come in with symptoms that don't fit that classic or typical picture of a pneumonia. So for example, they may have a dry instead of a productive cough, or they may have a low-grade fever, or instead of chest pain and shortness of breath, maybe they just have myalgias and a headache. This atypical presentation is usually going to occur due to infection from 3 specific bacteria. Now, at first glance, you may look at this and say, hey, that looks a lot like bronchitis or an upper respiratory infection, and you're right. However, it is just as important to identify and treat these patients as it is for their typical counterpart. Atypical pneumonia only accounts for about 10% of pneumonias, but within this group, the most common cause is going to be Mycoplasma pneumoniae, which will usually be seen in college students or military recruits living in close quarters. Now, be aware of chlamydophila pneumoniae as well, since it can come up from time to time on the boards, but another very important one to know is Legionella. Legionella is going to live in amoeba, so they're classically associated with contaminated AC units and cooling towers. Now, you should note that Legionella is not spread from person to person, just whoever is in contact with that contaminated water source. Often, these patients are going to have hyponatremia, LFT elevations, or diarrhea. So, if the question stem includes these factors, then the boards wants you to think about Legionella as your most likely culprit. Now, the boards keeps the diagnosis of pneumonia fairly straightforward. If you have a patient with a cough and a fever, and it doesn't matter if it's low grade or high grade, and a chest x-ray that confirms a pulmonary infiltrate, then you have officially confirmed the diagnosis of pneumonia. Whether it's typical or atypical, that doesn't matter. Now, sometimes these patients will have elevated white blood cell counts or elevated procalcitonin that will help to support the diagnosis. Or maybe they'll throw in a touch of hyponatremia to steer you towards Legionella. But remember, for the sake of the boards, if there is no infiltrate, there is no pneumonia. If they present a patient with a cough and a normal chest x-ray, then the boards are most likely suggesting bronchitis or some sort of upper respiratory infection instead. Now, real talk, this is very different from clinical practice because about 50% of patients who have pneumonia will have a normal chest x-ray and only have that confirmation when they get a CAT scan of their chest. But that is just too complicated for the boards, so you don't have to fret about that for now. Instead, just store that in the back of your head for when you're out there practicing. Now, the management of pneumonia is where the boards thrive, and that's because the treatment of pneumonia will be an antibiotic as a first line, obviously, but the choice of which antibiotic is going to differ based upon specific categorizations. Let's start off with the fact that if you have diagnosed a pneumonia in a patient who was recently hospitalized, or in a patient who develops a pneumonia at least 48 hours after being admitted, then this is considered a hospital-acquired pneumonia. And in turn, that's going to require very aggressive IV antibiotic treatment. Since there's a greater risk of acquiring superbugs when hospitalized, like MRSA and Pseudomonas, the treatment regimen for these patients must start with vancomycin for MRSA and other gram-positive coverage, and either Zosyn or Cefepime for anti-pseudomonal coverage and general gram-negative coverage. Now, there are some patients that are so sick that they require intubation and mechanical ventilation, but these patients can also develop a pneumonia while they're intubated. This is considered a ventilator-acquired pneumonia. Now, for the sake of the boards, these patients receive the exact same treatment as other hospital-acquired pneumonias. For the remainder of the patients, in other words, those who weren't recently hospitalized and instead, became sick with pneumonia in the outside world, we consider them to have community-acquired pneumonia. The antibiotic regimen for CAP is a little bit more complex, but let's start with patients who should be admitted to the hospital for IV antibiotic therapy. Now, these patients are generally quite sick and will usually present with one or more high-risk features like age older than 65, hypotension, some abnormal vital sign like tachypnea or hypoxia. They might have a high white blood cell count. They might look very confused from how little they're perfusing their brain because they have such a profound infection. Or they might have just failed outpatient antibiotic therapy, and so they need IV antibiotics. It's not important that you memorize this list, but more important that you kind of tackle this with common sense. If you had a patient in front of you who was hypotensive or breathing really fast, hypoxic, you probably wouldn't want to send them home. For patients who require hospitalization for their pneumonia, then the PANCE wants you to treat with IV ceftriaxone and IV azithromycin as that initial treatment of choice. Now, you should add on MRSA coverage with vancomycin if the patient recently had influenza or has a cavitary lung lesion that suggests staph as your cause. If the patient looks otherwise well and doesn't have any of those high-risk features, then they can go home with oral antibiotics. Now, that regimen will differ between if the patient has comorbidities or no comorbidities. If the patient has a medical problem that's going to increase their risk of treatment failure, pretty much any medical problem that makes the patient a little sicker than your average Joe, like heart failure, heart disease, COPD, HIV, immunosuppressive therapy, that list should be fairly obvious. But if they have any of those medical problems, then most likely they should be started on dual therapy with augmentin and azithromycin. Now, if the patient doesn't have any specific medical problems like just GERD or hyperlipidemia or something, then the PANCE wants you to send these patients home with single therapy only. If they have typical pneumonia symptoms, start them on amoxicillin or azithromycin. However, if they have atypical symptoms, then you should be choosing azithromycin exclusively, since amoxicillin doesn't really cover those atypical bacteria very well. Sometimes the PANCE will test you on the complications that are associated with pneumonia. Now, the classic way that the PANCE will test you on this is by presenting a patient who has persistent pneumonia symptoms despite antibiotic therapy. In that situation, you should perform a chest x-ray next, and often you're going to see blunting of the costophrenic angle. That is indicative of a parapneumonic effusion. In that case, the next step would be to tap that effusion with a diagnostic thoracentesis. The purpose is to find out if you have a simple effusion or if instead you're dealing with a complicated effusion or even worse, an empyema. In a simple parapneumonic effusion, an inflammatory process is occurring in the lungs and some of that has leaked into the pleural space. There's no bacterial invasion of that space yet, just some inflammatory process. For that reason, the pH will be usually normal, greater than 7.2, the glucose greater than 60, and the gram stain will be sterile. So you know that you're dealing with a simple parapneumonic effusion here, and the next step is just to continue antibiotics. Very important that you do not put a chest tube in these patients. They don't need one. Now, if the pH is less than 7.2, the glucose is less than 60, or that gram stain directly shows that there is a bacteria present, then that patient has now developed a complicated effusion. In that situation, there is actual bacterial invasion within that pleural sac, and it can't be eradicated without actual physical removal. Therefore, the most appropriate treatment is to perform a tube thoracostomy, and of course, continue the antibiotics. Now, if the thoracentesis shows just straight up purulence, then you know you're dealing with an empyema. In that case, the management is the same as a complex parapneumonic effusion, and again, you're going to insert a chest tube and continue your antibiotics. Now, there are other potential complications of pneumonia like sepsis or ARDS, but we're going to cover those in a separate video. Now, before we wrap up, make sure you can answer all these questions with confidence or go back and clear up any hesitations. Otherwise, we'll continue our talk on chest pain with our final topic, which is pericarditis. I'll see you there.